Dr. Thubrikar, thank you for joining the MedTech Unboxed podcast today.
Steve, thank you very much. I'm happy to join you and happy to be part of the podcast.
Excellent. I'm real excited to talk about the TAVI market and this issue with durability, especially as TAVIs are being indicated for a younger population now, right? And then there's this concern about durability, and we'll get into that in detail. But before we do that, why don't you tell us a little bit about Thubrikar aortic valve?
Right. So my whole career, just about except for the last bit of the starting the company, I was a professor and a researcher and a teacher and a happy-go-lucky man with the University of Virginia, then Carolina's Heart Institute, and so forth. But then with the lot of research we did, I wrote a book called The Aortic Valve. And when internet became popular, people with the disease of aortic valve, they would search and then my name would come up. And then they would call me, these patients. So I started getting random calls in Charlotte to only to find out that patients with aortic valve disease were calling me. And one day this woman calls me and says, Dr. Thubrikar, I want to talk to you. Well, the long story short, she had a 36-year-old son who is an athlete and had a aortic valve disease. She herself had a aortic valve disease, but she wanted to talk to me about her son, which was more critical case. So in the conversation, as as the conversation went on, she said, Dr. Bikar, why did you're so knowledgeable, you wrote a book, why did you not make a valve that my son could use? And she shook the earth under my feet at that time. And I basically had to choose between academics and making the valve itself. And so I left the academics and started a company, and we designed a valve which is mimicking the natural aortic valve. Because of years and years of research on aortic valve, I was able to mimic the characters. Many other people might say, and the companies might say, their valve is like a natural valve, but it's not.
Mm.
And it's really the depth of knowledge that is necessary. But that was a motivating factor to start the company. And it's been now 14 years. We did our first implant 8 years into the company. And we are kind of an unusual company, meaning we didn't have any big pocket investors, deep pocket investors with us. It's all friends and family who trusted me and invested and all. And then we got some companies that wanted license and angel groups, and then the doctors started coming in. So as a result of my background and our history, what we have achieved today, I don't think any other company would have achieved that without spending 2.5 times the money that we have spent. So we think we are doing really well, um, and we have great results in patients. So we are very pleased with it.
Dr. Thubrikar, that's an amazing story about how you got started with the mother of the 36-year-old calling you. And the book, curious, is the book still available like on Amazon? Can people still purchase the book?
Yeah. So this book, when it was printed in 91,
Hmm.
it was selling for $98. In 2012, 20 years later, it was selling for 500. $100 book going up in price to 500. I don't know how that happens. It's
Yeah.
not a Van Gogh.
Yeah. Yeah.
So, so I was puzzled. And the only explanation I have is the new technology of TAVR had started. The old surgical heart valve designers were let go because it was mature.
Yeah.
And now people were jumping in TAVR and they panicked and they were buying my book and it disappeared from the market essentially. Who buys a $500 book?
Right.
So, so, so it may stay. So now that was in 2012. Now, 10 years later, it probably come down in price because the field is
Yeah.
different,
Right.
but that's the story of it.
Wow. That's a great story. And but is so the book is if people wanna buy it today, they could still buy it on Amazon or is there
I
how do
would
you
think so. I would think
okay,
so. And I haven't lately checked, but
okay.
I think that it is available somewhere, eBay or
Yeah.
somewhere. Yeah.
Okay, excellent. How long did it take you to write that book?
Oh, I think in the university setting
Yeah,
with the physician's contribution and all that, it took me a little over 3 years.
okay.
Yeah.
A lot of
Because
work.
you can't just spend all the time writing the book. It's like you're working, doing your
Yes,
research, and working on the book.
yes, excellent. Again, thanks for sharing that. Let's get into it now and talk about, the unmet needs in TAVI. We talked about this durability issue and especially as it relates a TAVI transcatheter or percutaneous related to or versus a surgical heart valve. And let's get into it and along the discussion, if you can talk a little bit about the difference between a balloon expandable valve and a self-expanding, because I know there's a couple different modalities on the market.
Right. So the earlier um, business mover was Edwards, who bought a company out of Israel that was a balloon expandable transcatheter valve. So so they were the first movers, and then Medtronic jumped in. They bought another company and all that. And then for for practically 6, 7 years after that, most of the companies, startups and all, they copycatted. They copied the balloon expandable and copied the self-expandable. And so those are still the two platforms, and that is dominantly controlled by the two companies still, Edwards and Medtronic. They have over 94% of the world market in that.
Hmm.
And interestingly, this is with the knowledge that the companies know that they themselves have not the best valve. They already know. We don't need to tell them that because both of these companies had a surgical valve for years on end, and so they had a big market.
Yep.
Even though the valves were not the best, they became extremely successful money wise because no patient wanted open chest. Nobody wanted, and even now, you can tell them, well, look, I can't give, if a 50-year-old or 55-year-old person comes, they say, well, I can't give you a TAVI valve because you're going to come back in 4 years.
Yeah.
The person still say, oh, I'll see you in 4 years, but I just want no, don't open my chest light. It's like that. So there's a big issue going on between the patient and physician and how to deal with this. And so the balloon expandable valve has a disadvantage because you have to use a lot of pressure to expand the valve. Pressure in the order of 8, 9 atmosphere. In the car tire, we use little over 2 atmosphere pressure, little over 2. Here is a heart valve. You're now using 8 or 9 atmosphere pressure. So in surgical valve, they wouldn't even touch the leaflet with the pickups. They wouldn't even touch it. And here we are applying a huge pressures on the tissue with the balloon. So because of this potential damage to the tissue because of balloon pressure, the durability is compromised. And you can anticipate its compromise, but the proof is in the pudding.
Mhm.
So how do we know? As soon as they started implanting, they started seeing at 6 and 7 years, some patients have a degenerated valve. Yet they kept pushing to the younger patients. So now, for example, in a 73-year-old, uh, you have 43% failure at about 4 years. that's
It's
huge,
huge, huge,
huge.
huge.
And then you increase the age to say 80, you have the failures in the range of 4 to 7 years. Surgical valve adds at least 6 to 7 years to the durability. So, so in a younger patient, you have 12 years plus. In an older patient, you have 18 years or thereabout. So the lifespan is much, much greater. And now people are becoming almost in a panic. Oh my God, what do we do? What do we do? So, so when there was a heart valve meeting recently, for the first time, the cardiologists who do the TAVR, the cardiologists who organize the conference, they for the first time invited a cardiac surgeon to be part of the presentation because they wanted to understand what cardiac surgeon knew that these people do not know, that kind of thing. So the durability with the balloon expandable, but the durability is also issue with the self-expandable. And there's a second issue with self-expandable. Medtronic self-expandable, which is now copycat by other companies, it's a tall valve, like 5 centimeters. Well, what's the problem with it? The problem is as soon as you put that valve, the coronary arteries are behind the frame. So you have caged the coronary arteries.
Mm,
Well, what's the problem with that? The problem is you anticipate fair number of patients are going to require coronary stents because these are the people with a pathology of a heart
right,
valve.
right,
They are
right,
more prone to coronary stenosis. So if you cannot access the coronary, you have now given them a disease that they didn't have.
right.
So that is a big problem with it. So coronary access is a problem with the tall valve. And they also have a durability issue because they did not build the valve the way they were able to build the valve in a surgical area. And we have been able to overcome all those limitations. And we understand why the limitations they had, and they understand that they have the limitations. That's the interesting thing. We don't need to tell them, except that there's nobody to compete with them anyway.
Yeah, yeah. In catheter design, device design, we always hear that profile is king, right? And that usually means, lower, thinner wall thickness, so more devices, drugs, or whatever can be delivered through the lumen. But in this case, the self-expanding, we could talk about profile is just the height, right? The length.
Yes.
Interesting. So that's part of profile. It's interesting.
Yes. And that is the biggest issue
Yeah.
because nobody wants their coronary to have the grid in front of it.
Yeah.
Yeah.
Interesting. Okay, let's if we can, let's talk a little bit about the Optimum TAVI, and then we'll get into the Precision 2 delivery system. If you want to share your screen to get into that, that'd be great.
Yes, I think let me bring up the first slide and then
Okay,
we can talk with that.
sure.
Are you able to see my screen?
Yes.
Okay, so the the term optimum is I didn't pull this out of a blue sky. When I was studying why the nature designed our heart valve in a particular way. Our heart valve, the valve in the dogs, in the cats, in the rabbits, in sheep and in a child versus an adult, it all has a complete proportionality. It's almost like why is our head designed the way it is designed?
Hmm.
There's a rationale nature has created. And we embarked on figuring out why the valve is designed like that. And we found out that in order to open and close the door, it's like a open and close the valve. You have to flex the door, like you have to swing the door through 90 degrees. Same way you have to swing the leaflet through certain degrees. So in this determining that, we found out that the diameter at the bottom of the valve, the diameter at the top of the valve, the angle of the closing of the valve, the angle of the opening of the valve, the length of the leaflet, all that mathematically they are connected.
Mm.
Mathematically, they have to be optimized to achieve the best efficient function. So the optimized criteria was developed by essentially talking to the computer and having these equations to figure out what is the best design of the three leaflet valve.
Yep.
And the numbers that came out provided that this is the proportion. If you go away from this proportion, the valve would degenerate faster. So the optimization has been taken care of by the nature already. We simply have to understand how it did it, or or what is the principle of science or physics or math behind it. That's what we figured out. So the word we use here, optimum TAV, is because this valve is optimized exactly with the same parameters the way nature has optimized our valve. That's also the reason we call it the nature's valve by design.
Hmm.
So we have a natural geometry. We have no suture holes in the flexion zone. Mind you, you cannot open and close the door
Hmm.
without putting the hinges.
Yes.
If you had no hinges, you have to think about what do I do? What do I do? It's like a sail on a boat,
Yep.
you know? So you have biggest problem at the attachment if you don't allow it to swing open by the rotation movement like hinges. So in our valve, we found out that the flexion is the most challenging principle in the working of the valve. And so if you put the holes in the flexion zone, you are dead in water.
Yep.
And what has happened is in the TAVR technology, when when companies have so sutured the tissue to the frame, they use a surgical needle and use a surgical suture and go around it. So put a hole through the leaflet, go around the frame, and bring it back. All those holes in the flexion zone, they have not been able to get away from it. No company at this point in the world, no company is able to get away from holes in the leaflet in the flexion zone, which is the most challenging part of heart valve. Anyway, we overcame that. That is our secret sauce.
Mhm.
We overcame that. And that's one of the reasons why none of the valves are ever going to have a durability the way our valve has, you know.
Yeah.
So we overcame that and we have no sutures in the flexion zone. We use a self-expanding frame
Yeah.
so that there's no balloon issue or tissue damage. We use the lowest height
Mm.
or profile so you don't block the coronary arteries.
Yeah.
So with all of that, the valve has the most efficient function. And in the patient, where the proof of the pudding is, when we compare a 1 year follow-up data or a 2 year follow-up data, our valve has the most superior function compared to the commercial valves right now.
Huh. Which you said are 94 roughly percent of the market, right?
Exactly, exactly. And you know, these companies cannot wait to acquire our valve,
Mhm.
but they just don't want to be a part of R&D.
Hmm.
They say, Dr. T, you get the CE mark, get a European approval, then we'll talk to you.
Wow.
They simply want to build and sell. You know what I'm
Yeah.
saying?
Yeah.
Yeah,
Money
yeah,
machine, cash
yeah,
cow.
yeah. So I will tell you a little bit about catheter here
Yep.
because I don't have a picture down the road there.
Okay.
So our catheter, you can see a capsule is very small because the valve height is very small.
Mm.
So it is very easy to go around the bends. See, that's a big thing. Because
Profile.
if you make the capsule twice the length, it's that much harder to push through the curves.
Right.
And there are curves in our uh, thigh area, in our pelvic area, where you have to insert the catheter for implanting the valve. The handle is very easy to operate, and you rotate it and you push the valve out through here,
Hmm.
and then it is done like that. So catheter uh, operation also you will see. So I want to go to the next slide to talk about durability one more time.
Okay.
And the proof of the durability, everybody wants to say that you have to have a patient data for 10 years. Which company waits for 10 years before they make another model?
Hmm.
In surgical valve, every 3 years they would build a new model. And even in TAVR now, you have Edwards has valve A, then a valve B in few years, then valve C, and then same thing with Medtronic. You have A and B and C and D. Well, how did they decide in surgical arena that your new model is better than the old one? So there's a gold standard test that FDA and NIH figured out. And that is this test here on the right panel. The test is in the sheep. What they found out was in people, the younger the person, the quicker the valve becomes diseased, these prosthetic valves,
Hmm.
because the calcium metabolic rate is higher in a younger patient, like when you're building the bones, for example.
Yeah.
So, so the sheep turns out to be a model like a juvenile human being,
Hmm.
like a teenage human being. So, so they found out that if you were to show in sheep that your valve model B has a less calcium than model A, very simple. You just tell surgeon, hey, in sheep, this has less calcium than the previous model. So use this one. So that was used as a gold standard to promote the development as you created new model. Okay.
Okay.
So what we found is when we show our data of optimum valve, we have nothing to compare it with in TAVR field. Not a single company will show their sheep data. So we have to compare our data with a surgical valve,
Ah.
And so surgical valve also shows these little intensities of calcium,
Yeah.
which is more than the intensities here. And interestingly, you see these little dots,
Yeah.
tiny little dots. These are the dots in our valve that is in a place where the the tissue is not moving. It is like a non-moving part of the valve structure, but there's a hole there. See, even in our valve, if you create a hole, you can see a calcium, but in our valve, these holes are not part of a working valve. They are part of a rest of the architecture. So we have a proof in the sheep model that our valve has better durability or at least equal durability to surgical valve.
Hmm. That's huge.
And and we can't compare our data because none of the
Hmm.
big companies want to show their sheep data.
Hmm.
So you know how the old commercial was? Show me the beef.
Yeah. Where's the beef? Yeah.
Show me the beef.
Yeah. Yeah.
So I tell people, when big companies come to show you the valve,
Yeah.
you should say, you know what? Show me the sheep.
Yeah. Show me the sheep.
Show me the sheep.
Yep. And nobody wants to.
Nobody wants to. Nobody wants to.
Hmm.
Yeah. And the same companies will show the same sheep data in their next generation surgical valve. They'll show
Gotcha.
it for surgical, not for transcatheter.
Yeah. Yeah.
Interesting.
Yeah.
So here is, you can see the catheter at work.
Yep.
This is the video of the valve getting deployed in a patient. Hardly 10-15 seconds
Hmm.
to deploy. It's a very easy deployment procedure, very easy to use the catheter. You don't need, see, the
Yeah.
companies have started putting lots of bells and whistles on it because they have a fundamental problem they cannot solve. Ours is the simplest system with no 4 markers here to see and 2 markers there to see and blah, 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 and this knob and that.
Yeah.
It's crazy.
Hmm.
It's just crazy. It makes me feel, like graduate students who is doing a research work, but just beginning to do the research work and doesn't quite have a full understanding.
Yeah. Yeah.
So this is our catheter at work, and it is very nice deployment.
Yeah. I see that.
And then once it is deployed, you can see in a patient the profile, and you can see the coronary arteries up top.
Hmm.
You see,
Yep.
this is the other one here. So the left coronary, right coronary, they are completely free to be accessed by anything you want.
Hmm.
So we have solved the problem of we don't want to use the balloon and we don't need to block the coronary arteries.
Wow.
And the functionality of the functionality of the valve is as good as any that you can see. And none of the people would claim the durability the way we can claim. But they say, well, show us the 10-year data. Well, you never showed the 10 years data in surgical valve.
Yep.
You know,
Yeah. Right. Tell me the beef, the sheep.
show me the shape. Yeah.
Yeah.
Right. So I think maybe we can
Yep.
go back to not sharing now.
Okay. That's interesting. Thank you so much. It's kind of obvious in a way about suture holes and weak points, right? Which result in durability. And I didn't quite understand how you overcome that though. It's in the Optimum.
Right. I think you have to excuse me for that.
Yeah. Okay. No problem. You'd have to, if you told me, then we'd have to stop. Okay.
Yeah.
Got it. Got
Now
it. No problem.
you can meet me offside. We're
Yeah.
having beer. Maybe I should
Okay.
that with
All
you.
right. Yep. Understand. You talked about a little bit about the tortuosity and the delivery because of the shorter. We can relate that to profile, like we talked about, I guess. And is there any difference in transeptal crossing related to the two? Is there anything there?
So we are not doing the transeptal here because we don't need to. We go in the femoral artery.
Yep.
We go femoral artery, go to the aortic bifurcation. Femoral
Yep.
artery, go to the aortic bifurcation, go up the aortic arch, make a U-turn, and go to the valve.
Oh, okay.
Yeah. So
Gotcha.
it's percutaneous. It's a single puncture in the pelvic area.
Okay. You mentioned that pelvic. Okay. That threw me off a little. Thanks for going through that. That's awesome. Thank you so much. Let's talk a little bit about where you're at with clinicals, and I know there's some exciting things that you can maybe discuss there.
Yes, absolutely. When we compared the follow-up data, and this another thing, it's I'm learning a lot of things in the business arena now that is very different from the university setup where I spent so many years of my career. So in the business world, the companies decide to present the data in a certain way, which benefits them. So what was happening is that when we are implanting our valve, because these are early studies, we didn't want to use too many sizes of the valve. We use one size of the valve to get enough data. So we have now 12 patients. So in the earlier part of 1 month to 3-month follow-up, we wanted to compare the data. And we found that only two companies, Edwards and Medtronic, and the data was published by Columbia University people in the paper. That is the only data. Think about it. The only data that separates the data on the basis of size stuff of the valve. Size A, size B, size C. What? So you're looking at, say, size 23, size 26, size 29, whatnot.
Yep.
Subsequent to that, they combine all the sizes and present the data of the group. Well, if you have a size 23 valve, you don't want to compare it with size 26. You want to compare it with size 23.
Yeah. Right.
So that is the data we have used from Columbia University publication. Where at that probably I've only come across that presentation that deciphers the data on the basis of size. So in that comparison, the patient data set says that the performance of our valve is better than the two platforms, which is a balloon expandable and a self-expandable.
Okay.
Yeah. Yeah. So we already have compared that. Now we have 12 patients. We have no adverse events, no pacemaker, no big leaks,
Mhm.
and great results with respect to hemodynamic performance of the heart valve. Just like I said, if I compare, and then it's still simple too. Adverse events, you can simply say, oh, how many patients you had pacemaker? How many patients you had leak? Those are interesting and simple, straightforward.
Yeah.
Well, we have none of those to even compare because ours is zero. No,
Oh,
zero pacemaker, zero big leaks, any of that. So that part is out.
yeah.
So performance is checked with respect to effective orifice area and pressure gradient. That is what they measure on echo as the follow-up. So when we compared our pressure gradient of the valve and effective area of the valve with the balloon platform and a self-expanding platform, our data is superior to their data, which is a limited data published in only one paper.
It's amazing. That's amazing. Thanks for sharing that. Let's talk about the future. What's the outlook for clinicals and also funding?
Yeah, so it is interesting the way the field has gone. We thought that we would have easiest time to get funding, or we even be sold out once we proved the durability
Hmm.
in sheep. But the field was very dynamic. That so many things were happening, so many people were getting involved, and so much and very fast expansion of work because of the patients. Just surgery was going down, 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 transcatheter going up, 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 very fast. I think the first year revenue of Edwards was something like $640 million, something like that, you know. So now the market is probably 5-6 billion a year and still growing,
Probably
still
more.
growing.
Yeah. Yeah.
So we thought that it would happen like that, but it didn't. It didn't. We didn't get any big checks. We didn't get any buyout offers and all that. But as we have increased the patients now, more and more people are talking. But we still need funds to do a complete European approval. So we are working on European approval. We have 12 patients in Europe doing fantastic. Pre-COVID, we did one patient in Brazil. She's at 6 years now, and she is doing fantastic. And her valve performance numbers and the 12 patients performance numbers in Europe, you can't tell the difference.
Hmm.
It's all part of the same thing, it looks
Yep.
like. So it is really great. And we have to go to Europe because all the big companies, if FDA deserves a bit of a blame in this, all the big companies went to Europe first They got a European approval first. They started commercializing. Then they started collecting the data on those patients, commercialized patients in one or two centers. And then FDA, Medicare, and the companies, they sat down together. And would you believe they brought, in my opinion, they brought the FDA and Medicare to their knees. They would not, they said, we don't want to bring the valve to US. We don't. You guys are not so good. You push us to go to Europe.
Mm.
I'd asked this question to Hillary Clinton in one of the conferences,
Mhm.
which she sort of addressed in a political way.
Yeah.
But I'd said, and I still say, it's an American idea, American money, American development, proof of concept, the preclinical, sheep and all that. Then go to Europe,
Mm.
give the money to Europe, train the doctors in Europe, then bring the doctors to America to train the American doctor. It's oxymoron. Who does that in the world?
Right.
Only we do that.
Yep.
And why do we do that? Because of the rules and regulations in FDA. So FDA and Medicare agreed, which is a really great thing, that they would actually pay for clinical trial in the US. Then the companies agreed they will do the trial in the US. Edwards was the first one. And it looks to me like Edwards said, you know what? Unless I get paid, I have no reason. I did my clinical trial there in Europe. I don't want to do clinical trial. And they paid for the clinical trial in the US. So they changed the rule at that.
Yeah.
And 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 it is still difficult in FDA. When we go and talk to them, say, well, we want to do some work here. They say, okay, do you have a 1, 2, 3, 4 up to 50 points done first? Well, if you are a startup company, you can never do 50 things.
Right.
So that's the problem. So anyway, so
Mm.
now we have 12 patients in Europe, and we are going to do limited implants in the United States and Canada, maybe like 10 or so
Okay.
implants in the US and Canada. And the reason, Steve, is investors we're talking to, they say, oh, you have any patients in the US? We say, well, they are all Caucasian there in Europe. That
Mhm.
we have
Yeah,
huge.
yeah.
But they still say, it's a business mind. They still say, you know what, we want to see at least a couple of patients in the US. So we're going to do 8 or 10 patients in the US. Right now, we're planning on that. So that is the stage. So our focus is do limited patients here, get the investment, complete the European trial, then come back to do the US trial,
Okay.
just like the big companies did.
Excellent. Okay. Well, this has been a great discussion, Dr. Thubrikar, and I look forward to following the progress as these activities that you just mentioned. It sounds seems to me that it's a very elegant design that kind of takes care of some of these limits or gaps in the market with sutures and weak points and durability. And so I really appreciate you taking the time.
And in the process of these implants, our physician is in Poland. He uses uh, 5 commercial systems in his routine tower. In
Oh,
a lot of the hospitals, they have Tuesday, Thursdays, only tower. Tuesday, Thursday, only tower. So he has the same process. So he uses 5 commercial systems. When he used our implant system, he made a comment, which we put it on our business press release. He says he wishes that his routine towers were as easy and simple and effective as our valve.
hmm.
He wishes.
The key word, and you mentioned it a few times, is simple. Keep it simple.
Yeah, and he knows how well the patients are doing.
Mhm.
They discharge on the day 2, day 3, which is in most of the cases. but in terms of the functionality of the valve, how well patients are doing, and and if you were to believe that the sheep data will translate into human data few years down the road, then you have an amazing situation.
Yeah. Excellent. I look forward to following it, and I wish you the best of luck in these clinicals and funding as well.
I thank you very much for giving the opportunity to be a part of this podcast.